Imagine you're standing in front of your bathroom mirror. You're just going about your normal morning routine.
Right.
Maybe you're washing your face or shaving or adjusting the collar of your shirt. And as your hand brushes across your neck, your fingers just stop.
Yeah, that terrifying moment.
Exactly. You feel a lump. It's this distinct, undeniable mass right there in your neck. And you are absolutely certain it wasn't there yesterday. Your heart rate instantly spikes. So what happens next?
Well, it's a massive cascade of anxiety. I mean, it's the exact moment you transition from just a person going about your day to a patient who is suddenly standing at the entrance of this incredibly complex medical labyrinth.
And navigating that labyrinth is exactly what we're doing today. So welcome to today's deep dive. We are pulling back the curtain on the high-stakes world of medical decision-making in head and neck surgery.
It's a fascinating area.
It really is. Our mission today is to decode the exact stepwise logic that surgeons use to solve the mystery of a neck mass. We're looking at excerpts from the clinical textbook, Decision-Making in Otolaryngology, specifically chapters 145 and 146.
Right, which are basically the blueprints for this stuff.
Yeah, it's essentially a masterclass in clinical deduction. We're going to see how doctors avoid dangerous diagnostic traps and, how modern medicine balances incredibly low-tech physical exams with, futuristic robotic interventions.
Okay, let's unpack this.
Let's do it.
Because I think the natural assumption for anyone who finds a lump is that the doctor's immediately going to order a barrage of high-tech scans.
Yeah.
Like you want the MRI, the CT scan, the PT scan.
Oh, absolutely.
You want the $1 million laser grids to give you an answer in 5 minutes.
Right. That is the instinct, for sure. Both for the terrified patient and, honestly, sometimes even for less specialized practitioners. You just want the technology to hand you the diagnosis on a silver platter.
Yeah, of course. But in head and neck oncology, doing that is actually the exact wrong first move. I mean, jumping to unnecessary and expensive investigations like a PT scan too early in the process is a massive pitfall. The textbook warns against this constantly.
Which feels completely counterintuitive. I mean, if we have the technology, why not use it immediately to see what's under the skin?
Because a scan gives you a picture, but it doesn't give you clinical context.
Ah, okay.
It can easily lead you down a very expensive, very stressful rabbit hole of false positives. The root cause of the vast majority of neck masses in adults actually becomes completely apparent after a careful traditional history and physical exam.
Really?
Yeah.
Just from talking and looking?
Yeah. The first goal isn't to blast the neck with radiation. The first goal is to rule out a primary issue in the upper aerodigestive tract. So, the mouth, the throat, the voice box.
So the doctor is essentially mapping the local hardware before plugging in the supercomputer.
Exactly. They're looking for very specific low-tech clues. They'll ask things like, do you have dysphagia, which is difficulty swallowing,
Right.
or odynophagia, meaning painful swallowing,
Right.
or dysphonia, which means sudden changes in your voice, like hoarseness.
And they aren't just asking those questions to be thorough, right? They're trying to figure out what the lump is pressing against inside there.
Spot on. Yeah, if your voice is suddenly hoarse, it tells the surgeon the mass might be pushing directly on the recurrent laryngeal nerve, which is what controls your vocal cords.
Oh, wow. So a simple question about your voice tells them exactly where the tumor might be rooted.
Precisely. And they're also looking for the imposters.
The imposters.
Yeah, these are diseases that look exactly like head and neck cancer, but are entirely different beasts. What's fascinating here is how something as historic and ancient as tuberculosis is still a primary suspect in these cases.
Wait, really? TB, like the Victorian era disease.
Yes, exactly. TB can present as massive lymph node swelling in the neck. Historically, it was called scrofula, and it can perfectly mimic the presentation of a carcinoma of the larynx or pharynx.
That is wild.
It is. And similarly, the HIV/AIDS virus is strongly associated with swollen cervical nodes, as well as Kaposi's sarcoma and lymphoma.
So thinking about this logically, the surgeon's approach is basically a funnel.
Right.
Instead of instantly throwing you into the narrow, highly specific, and frankly, very expensive end of the funnel with a PET scanner, they start at the widest part, the human touch.
Yes.
Simple questions about your throat, checking your voice, and testing for masquerading diseases like TB or HIV that could easily fool a scanner into thinking it's looking at a tumor.
Exactly. Because you don't want to subject someone to the radiation of a CT scan or cut their neck open for a biopsy. If a simple lab culture shows they just have a bacterial infection that can be cleared up with 2 weeks of antibiotics.
Right, that makes total sense. But let's say the doctor uses the wide end of the funnel. You don't have TB, you don't have an infection. Your voice is fine, swallowing is completely fine, but that mass in your neck is still there.
Right. Then things change.
Yeah, this is where the source material says the protocol shifts from just gathering clues to making a very dark presumption.
It does. It shifts to the golden rule of head and neck oncology. The cardinal rule is this. In an adult, an unexplained neck mass is considered metastatic cancer until proven otherwise.
Until proven otherwise. Man, that's a heavy sentence. They don't assume it's a harmless cyst. They assume the absolute worst from the jump.
They have to. And this probability is actually rising due to the increasing prevalence of HPV-related cancers.
Really?
Yeah, specifically in non-smokers.
Yeah.
Decades ago, if a non-smoking adult with no history of heavy drinking had a neck mass, cancer might have been way lower on the suspect list. But today, the human papillomavirus has fundamentally changed the demographic of head and neck cancer.
Wow.
So the assumption must be malignancy.
And this brings us to a massive diagnostic trap, which I found totally mind-bending when reading the text. The danger of the cyst deception.
Oh, this is a huge one.
It's a perfect example of why you can't blindly trust a scan. Can you explain that?
Yeah, let's say a doctor did jump the gun and ordered a CT scan of that neck mass. The imaging might come back showing what looks exactly like a benign fluid-filled cyst. It looks perfectly harmless on the screen.
Right.
But in reality, it could be a highly malignant lymph node. To confirm, the primary tool they use is a fine needle aspiration biopsy, an FNIB.
Okay, the needle biopsy.
Right. They stick a thin needle into the mass, dry out some cells, and look at them under a microscope. But the false negative rate for doing this on a cystic neck mass is a staggering 30%.
Okay, wait, I have to pause here. If the surgeon literally sticks a needle directly into the lump, pulls out fluid, and the pathology lab says there are no cancer cells here, how on earth can they still assume it's cancer almost a third of the time?
Because of the 30% failure rate.
Are the doctors just missing the target because the lump is full of liquid?
No, it's not that they're missing the target. It's the biology of the tumor actively deceiving the test.
Deceiving the test? How?
Well, let's look at the mechanics of what's happening inside that lump. When a metastatic lymph node grows very quickly, the cancer cells on the outer rim multiply so fast that they actually outgrow their own blood supply.
Oh, wow.
Yeah. And because the blood vessels can't keep up, the cancer cells right in the center of the node suffocate. They begin to die off, and they actually liquefy. This is a process called central necrosis.
So the tumor is essentially rotting from the inside out.
Exactly. It creates a dead liquid center surrounded by just a very thin rim of active living cancer cells. So when the CT scanner looks at it, it sees a fluid-filled sac, and the radiologist thinks, oh, it's just a harmless cyst.
Right.
Then when the surgeon puts the fine needle in, the needle goes right past that thin outer rim of active cancer and lands perfectly in that dead liquefied center.
Oh, I see.
They aspirate the fluid, send it to the lab, and the pathologist sees only dead cellular debris and fluid, no active cancer cells, hence a false negative.
Wow, that's insidious. The cancer literally hides behind its own dead tissue.
It's a biological smokescreen. That's why a negative needle biopsy on a cystic neck mass is never ever trusted.
So what do they do?
Well, a negative result mandates a repeat biopsy, maybe using a thicker core needle to grab actual tissue instead of just fluid, or eventually the surgeon might have to open it up. But they have to remain deeply suspicious.
Right.
Now, if that needle biopsy does come back positive, and specifically if it tests positive for P16, which is the molecular marker indicating an HPV-positive cancer, the entire diagnostic search must immediately pivot away from the neck.
Here's where it gets really interesting, because the neck mass, the lump you felt in the mirror that morning, is just a symptom.
Yes.
It's just a secondary metastasis. The real killer, the primary tumor, is hiding somewhere else entirely.
It's exactly. Finding a biopsy-proven metastatic cancer in a lymph node with no obvious primary source triggers a massive high-stakes search. The node in the neck is basically just sounding the alarm, but you have to find the fire.
Right.
It requires pivoting straight to the oropharynx, so the tonsils and the base of the tongue.
It's like an environmental tracking problem.
Yeah.
Imagine finding a massive, highly toxic pollution spill in a major river. That's the large neck node you can physically feel.
That's a great way to look at it.
But the factory causing all that pollution is a microscopic 2mm pipe hidden deep inside a cave upstream, and that cave is the base of your tongue.
And finding the microscopic pipe means the supercomputers finally fail us. I mean, you would think a PET scan would easily find it. A P scan highlights areas of high metabolic activity in the body, which, usually lights up cancer like a Christmas tree.
Right.
But PET scans have a critical blind spot. They routinely fail to detect small tumor deposits that are under 1 centimeter in size. They just don't generate enough metabolic heat to register on the scan.
Under 1 centimeter. And the text notes these primary tumors, the hidden factories causing these massive neck lumps, are sometimes just 2 to 3 millimeters in size.
Literally tiny.
That's the size of a sesame seed. So how on earth does a surgeon find a sesame seed-sized tumor hidden in the folds of someone's throat?
They have to go in manually. Yeah. The patient is put under general anesthesia for a procedure called a panendoscopy, where the surgeon examines the entire upper airway and digestive tract with scopes.
Okay.
But even a camera isn't always enough, because a 2mm tumor might be buried deep inside a crevice in the tonsil tissue. So surgeons will perform routine tonsillectomies. They just remove the tonsils entirely on the side of the neck mass to send to pathology.
Wow.
And they also take directed blind biopsies of the base of the tongue.
Because these primary tumors are so critically hidden, the sources point out that many surgeons are now routinely using robotic excision.
Oh yeah, robotics are huge here.
They literally send surgical robots into the base of the tongue to carefully dissect and search for that microscopic primary tumor because the angles are just too tight for human hands. You have to send in the robots just to find the pipe.
The precision required is immense. And even with scopes, tonsillectomies, and robotic tongue-based resections, sometimes they still can't find the primary tumor. It's just too small.
So what happens then?
In those cases, the protocol is to irradiate the likely hiding spots anyway. They deliver radiation to an area called Waldeyer's ring, which is the main ring of lymphoid tissue in the pharynx, just to ensure that the invisible factory is destroyed.
Okay, so knowing how incredibly difficult it is to find the source, and knowing that needle biopsies miss the cancer 30% of the time when it's cystic, I'm looking at this from the perspective of a panicked patient.
Understandably.
If human nature is screaming, I don't know what this lump in my neck is, it might be cancer, just get it out of my body right now, why don't doctors just cut the whole neck mass out immediately to look at it under a microscope?
Oh, that's a terrible idea.
But why? Why do all this needle biopsy and robotic tongue searching when the lump is right there on the surface?
Because in head and neck oncology, there's a cardinal sin. You never, ever just slice into an undiagnosed mass. You have to fight the temptation of an open biopsy.
But if the goal is to figure out what it is, how does a simple cut to remove the lump ruin things?
If we connect this to the bigger picture, think of the next tissue like the intricate wiring and plumbing inside the walls of a house.
Okay.
If you just take a sledgehammer to the drywall to pull out one bad electrical outlet, which is your open biopsy, you might blindly sever the main power lines and water pipes.
Right.
Later, when you actually need to rebuild that wall, you have no infrastructure left.
Yeah.
In surgical terms, cutting into the neck prematurely ruins the delicate tissue planes needed for pedicled flaps during reconstruction.
So you're destroying the vascular roadmap.
Exactly. If the surgeon eventually needs to rebuild part of the patient's throat or jaw after removing the cancer, they rely on moving flaps of skin and muscle from the neck up to the face while keeping their original blood supply completely intact.
Oh, wow.
Yeah. If a previous surgeon carelessly sliced through those specific blood vessels just to pull out a lymph node, that reconstructive option is gone forever. Furthermore, violating the neck tissue inappropriately can actually seed cancer cells into the surrounding clean tissue.
Making it spread faster.
Right, which forces the patient to undergo severe adjuvant radiation therapy that they could have otherwise avoided completely.
So hands off the lump unless you know exactly what your long-term surgical plan is.
Yes, with one major exception, lymphoma.
Right. Why is lymphoma the exception to the do not cut rule?
Because of how lymphoma is diagnosed. A needle biopsy can only suck out a soup of individual cells. It can tell the pathologist, hey, these cells look like lymphoma cells, but it can't tell them exactly what subtype of lymphoma it is.
To
conclusively classify the disease, the pathologist needs to see the entire structural architecture of the lymph node completely intact. They need to see how the cells are physically arranged within the capsule of the node itself.
That makes sense.
But you can't see the architecture of a house if you just put a pile of bricks in a blender. So for lymphoma, conclusive diagnosis actually requires the surgical excision of the whole node. But again, that decision is only made after a needle biopsy strongly suggests lymphoma first.
The choreography of all this is just wild. We've been treating the neck like a hiding spot for cancer this whole time, but it's also an embryological highway.
Yes, it is.
As we develop in the womb, a lot of structures travel down the neck, and sometimes they leave behind ghosts. Bizarre, non-cancerous anomalies that suddenly swell up decades later and terrify people.
It's true. The anatomy of the neck is incredibly complex because of those embryological structures that fail to disappear properly. A classic example of the text outlines is the fibroblastic duct cyst. These cysts occur along a tract between the base of the tongue and the mediastinum, which is the central compartment of the chest cavity where your heart sits.
And they have this fascinating physical quirk. Actually, let's do a little interactive anatomy check for you listening at home. Right now, wherever you are, I want you to swallow. Or, if you're not in public and won't get weird looks, stick your tongue out.
That's actually a great way to visualize it.
Yeah. When you swallow or stick your tongue out, you can feel the structures in your throat moving upward. If a patient has a thyroglossal duct cyst near their hyoid bone, which is that little horseshoe-shaped bone right in the middle of your neck that anchors your tongue, the lump will physically move upward when they stick their tongue out.
Yes, and that simple visual cue, just watching the lump bounce when the tongue moves, tells the surgeon exactly what they're dealing with.
It's like a puppet on a string.
Exactly. It's a fluid-filled remnant connected to the path the thyroid gland took when it descended from the base of the tongue down into the lower neck during early fetal development. But treating it is no small feat. It requires what's known as the cyst trunk operation.
And the cyst trunk operation sounds intense. They don't just, pluck out the cyst like a grape. They have to remove the cyst, the entire tract it leaves behind, and they actually have to cut out the central body of the hyoid bone, along with a solid core of muscle, all the way up to the base of the tongue.
It's extensive.
They carve out a tunnel just to make sure this benign, fluid-filled ghost doesn't come back.
It's a profoundly radical surgery for a benign condition. But if you don't take the bone in the tract, the recurrence rate is incredibly high. Now, beyond cysts, you also have nerve sheath tumors, like schwannomas and neurofibromas. These arise from the sheaths covering the cranial or peripheral nerves in the neck.
Let's break those down, because how they grow is fascinating. Let's look at schwannomas.
Schwannomas grow from Schwann cells, which are essentially the protective, rubbery insulation wrapping around your nerve fibers. Yeah. What's interesting about schwannomas is that they are very slow growing, and initially, they preserve the function of the nerve they're attached to.
So a patient might have a massive lump on a major nerve in their neck, but absolutely no numbness, no vocal paralysis, nothing.
Right.
How is that mechanically possible?
Think of a nerve like a thick bundle of individual copper wires wrapped in a rubber casing. A schwannoma grows on the outside of that casing. As it gets bigger, it pushes the entire bundle of wires aside, acting like a wedge, but it doesn't actually sever the internal wires.
Oh, I see.
So the nerve keeps firing. Contrast that with a neurofibroma, which grows deeply intertwined inside the nerve bundle itself, tangled in the wires.
Ouch.
Yeah. Neurofibromas are much messier to remove, and they're often tied to von Recklinghausen's disease, which is a genetic condition where over 50% of patients have a positive family history of these tumors all over their bodies.
And speaking of family history, that brings us to one of the rarest oddities the textbook mentions, paragangliomas. These arise from neuroectodermal tissue, basically the early embryonic cells that eventually become your nervous system. Now, a lot of medical literature contrasts them with pheochromocytomas.
Right, let's translate that.
Yes, please. Pheochromocytomas are tumors usually found on the adrenal glands above the kidneys, and they act like rogue factories pumping massive amounts of adrenaline into the bloodstream.
Exactly.
Paragangliomas are essentially their neck-dwelling cousins, often growing near the carotid artery. But unlike the ones on the kidneys, these neck tumors rarely secrete those adrenaline hormones, which are called catecholamines. means.
Rarely, but not never. And this raises an important question about the limits of a physical examination. If you have a patient with a lump pulsing next to their carotid artery, how do you check if that tumor is secretly pumping adrenaline into their bloodstream?
I mean, I would assume you order a blood test.
You don't immediately order a complex blood draw. You ask the patient. You say, do you have sudden, unexplainable palpitations? Do you get random, severe flushing in your face? Do you have terrifying spikes of hypertension out of nowhere?
So you're basically asking if they feel like they're randomly being chased by a bear while sitting on the couch.
Precisely. If the patient says yes, and especially if they mention a family history of multiple similar tumors, the doctor immediately knows to evaluate for catecholamine secretion.
Wow.
They have to stabilize the patient medically before ever attempting surgery. Otherwise, just touching the tumor could release a fatal flood of adrenaline. Again, it's a simple targeted conversation, beating a blind scan to the punch.
So what does this all mean? When we look at this entire journey, from the moment you find that lump in the mirror to ruling out ancient diseases like TB, to avoiding the trap of the false negative cyst, to sending robots to find a 2mm factory in the tongue,
It's a lot.
and fighting the urge to just sledgehammer the wall to get the lump out, it seems like medical decision-making in the head and neck is really about fighting human instinct.
Absolutely.
It's about fighting the instinct to rush, the instinct to jump to the highest tech, most invasive option, and instead deeply trusting the biological behavior of the disease and following a strict logical choreography.
It really is a masterclass in disciplined restraint, and that theme of restraint continues even after the cancer is found and treated. I want to leave you with one final lingering thought from the text section on post-treatment care.
Okay, let's hear it.
Let's say a patient goes through this whole gauntlet. The microscopic primary tumor is found, and they undergo intense radiation and chemotherapy to cure the cancer.
The ultimate biological war.
Exactly. After the treatment is done, patient naturally wants to know, am I cured? Is the cancer gone? The doctors use a PET-CT scan to check for residual cancer, but they absolutely cannot do this scan immediately. They have to wait more than 3 months after the treatment finishes.
3 months? That sounds agonizing. Why wait that long when you desperately want to know if you're cured?
Because the radiation and chemotherapy cause so much intense local inflammation in the tissues of the neck. The tissue is so angry, so inflamed, that if you scan it too early, the PT scan will just show a massive glowing area of high metabolic activity.
Oh, because healing also uses energy.
Exactly. The scanner literally can't tell the difference between the ghost of the dying cancer and the body's own healing fire. The treatment is so dramatic, and the biological battlefield is so chaotic that for months, modern medicine has to simply step back, wait for the smoke to clear, and let the body settle before they can truly know if the war has been won.
Waiting for the smoke to clear, it really brings it all back to that first moment at the mirror. Finding the lump is instantaneous, but the journey to understand it, map it, treat it, and ultimately know it's gone requires an incredible amount of patience, logic, and profound respect for the complex wiring of the human body.